everyone. I'm Dr. Shargil. I'm going to be the moderator of this grand round. And I'm pleased, honored to present Dr. Rizwan Malik, which is presently a consultant ophthalmologist in the glaucoma division at King Khaled Eye Specialist Hospital. Dr. Malik is well known by all of us. He completed his PhD thesis entitled Investigation of Psychophysiological and Electrophysiological Changes in Primary Open-Angle Glaucoma under the direction of Professor Ted Garvey-Heath and Fred Fitzke at Moorfield Eye Hospital and the Institute of Ophthalmology in London in 2010. He served as a resident at the Royal Eye Hospital in Manchester and then as an academic clinical lecturer at Moorfields Eye Hospital, where he has funded by the National Institute of Health Research. He completed glaucoma fellowship at the Department of Ophthalmology and Visual Science in Halifax, Nova Scotia, Canada, and a second glaucoma fellowship a year later at Moorfields Eye Hospital. And Dr. Malik is not only one of the best glaucoma specialists I have met because of his deep knowledge in glaucoma, but also for his commitment and well care with patients, residents, and fellowships. We couldn't let him go without giving us his last lecture as a consultant with us. Thank you, Rizwan, for accepting the challenge and the invitation to give us the grand round. And please go ahead whenever you are ready.
Thank you very much. Can you hear me, Conrad? Is the sound clear?
Very, very good, Malik, very good.
Excellent. Well, thank you very much for that introduction. And it's really a pleasure to present this lecture again. Some of you might have heard bits of this lecture before. And it's a lecture on pseudoexfoliation, as we see a lot of this condition here in Saudi Arabia. So why talk about pseudoexfoliation? Well, there are a number of different reasons. First of all, the condition has a high prevalence in some parts of the world, and that includes the Scandinavian countries, but also includes parts of Africa and parts of the Middle East, like here. We certainly see a lot of pseudoexfoliation here. The second reason is that the condition carries a high visual comorbidity, and patients are more likely to go blind from pseudoexfoliative glaucoma than from primary open-angle glaucoma or normal tension glaucoma. And we have some good data on this in the EMGT, which we'll come on to later. But they not only lose vision from glaucoma, but they lose vision from cataract as well. And of course, that's a reversible cause of visual loss. And thirdly, and lastly, this I think is a pretty intriguing condition. There's a lot that really not known about pseudoexfoliation and the mechanism behind the disease. And let's not forget, it's a systemic condition, and there has been some association with increased mortality in patients with pseudoexfoliation. So coming on to visual comorbidity, this is data from the early manifest glaucoma trial, which was a trial where they took glaucoma patients and they randomized them to treatment or no treatment. Okay, so one arm had no treatment, and the reason for that was to look at the natural course of the condition. How do patients progress if they're not treated? And this shows the progression in patients with high tension or primary open-angle glaucoma, normal tension glaucoma, and pseudoexfoliative glaucoma. So if you look at the this normal tension glaucoma, you see they progress the least, and that's what we'd expect really. And if you look at this pseudoexfoliative glaucoma, you can see that at 60 months, which is 5 years, more than 80%, 85% of the patients progressed within 5 years. So if you have pseudoexfoliative glaucoma compared to normal tension or primary open-angle glaucoma, you're more likely to lose vision over time. And the vision loss, like we said, is not only from glaucoma. This is data from the Blue Mountain study, which was a large epidemiological study done in Australia. And they looked at patients who had pseudoexfoliation and who didn't have pseudoexfoliation. And what they found was that in patients with pseudoexfoliation, the rate of nuclear cataract was far higher. And if you had pseudoexfoliation, you were almost twice as likely to have cataract, nuclear cataract, compared to if you didn't have pseudoexfoliation. And of course, cataract surgery is not straightforward in some of these eyes, so that's an important finding as well. So let's go on to the overview of the talk now that we discussed why it's important to know something about it. So we're going to talk about what it is, the epidemiology, the clinical presentation, the treatment options, cataract surgery, and systemic associations. So what is pseudoexfoliation? Well, pseudoexfoliation is characterized by a deposition of abnormal basement membrane material throughout the anterior segment. And this is a typical presentation that we see in the clinic, where we notice patients with pseudoexfoliation who might have glaucoma or who may not. And you see this abnormal material at the pupillary zone and within the central lens capsule. And this is usually separated by a clear zone. And some people describe this as a target or bullseye lesion. And the clear zone arises because of the iris rubbing in the center part of the lens, or peripheral part of the lens rather. And we know this condition have a strong association with glaucoma. Now, the history of this condition is pretty interesting. It was described by John Lindberg in 1917, and he was actually a resident of Axenfeld, who was another famous Finnish ophthalmologist, and he followed on some of the observations of Axenfeld. Axenfeld described a hyaline degeneration in eyes with pseudoexfoliation. He noted this in elderly people. And John Lindberg, as part of his resident thesis, made his own slit lamp to study the condition further. And he described the hallmarks of the condition, which is what we really know about still today, which defines the condition. And he described these gray flecks on the anterior lens capsule and glaucoma occurring in about 50% of the eyes. And he noted that the condition prevalence was related to age. So the older people were more likely to have this. Interestingly, actually, he discussed some of his findings with some of the ophthalmologists in about 1922, and including Vogt, and they published their papers on the condition before he did. So they stole some of his show, as it were. Later on, Dvorak Theobald coined the term pseudoexfoliation instead of just exfoliation. And this was to distinguish the condition from true exfoliation, which was found in glass blowers at the time, which was due to thermal delamination of the anterior lens capsule. And this is a nice case report on that same theme from Deepak Edward and Samuel Dabe from here, where they present a patient who had both true and pseudoexfoliation within the same eye. And they proved this histologically, that the exfoliation and pseudoexfoliation were characteristically different histologically. And the true exfoliation in this patient was thought to be due to sunlight kind of damage to the anterior lens capsule, rather than true glass blowing induced UV radiation. So what happens at pseudoexfoliation? Well, the pathogenesis is not completely known, but it's thought that a cellular stress or oxidative stress leads to an increase in TGF-beta within the eye and within the body, and that leads to an upregulation of matrix metalloproteases, which then causes degradation of matrix within the eye and within the body. And that can be seen in the eye because obviously the cornea is clear and we can see the deposition of material there. In terms of epidemiology, is classified as the most common identifiable cause of open-angle glaucoma worldwide. We know here that obviously it's associated with both closed-angle and open-angle glaucoma, and we see a lot of narrow angles in these patients as well. But that is not common elsewhere in the West. It has an increased prevalence with age. Generally, it's rare under the age of 55, and people over 80 have an increased prevalence of pseudoexfoliation. It can occur in almost any population, and the Scandinavian population has a high prevalence of pseudoexfoliation, particularly those above 80. Up to 40% of those Scandinavian people above the age of 80 will have pseudoexfoliation in epidemiological studies. But you don't have to be white to get pseudoexfoliation. In India, about 8% of patients have pseudoexfoliation. Interestingly, in other populations, the white populations carry a higher prevalence compared to the black populations, even within the same country. So within the US, the Native Americans has a population of a prevalence of nearly 40%, whereas the African Americans has a prevalence of less than 1%. And even within Africa, the same pattern follows. The West Africans have a much lower prevalence, and the South African whites and blacks have a higher prevalence of pseudoexfoliation. And interestingly, the Aborigines, Australian Aborigines, seem to have a higher prevalence of pseudoexfoliation, but for some reason, they rarely tend to get glaucoma, and they're thought to have some kind of genetic resistance to developing glaucoma. So even studies here done in Saudi Arabia, we find that the prevalence of pseudoexfoliation increases with age. And you can see this study done in 2015, that patients below 50 years old, the frequency of pseudoexfoliation was less than 1%, and patients above 80 years old, the prevalence was almost a quarter. Now, one of the difficulties is, how do you pick up pseudoexfoliation? How do you classify it if you're doing an epidemiological study? Particularly, in pseudophakic eyes, it can be difficult to pick up. So there are various classifications that have been developed, and most of these are based on the presence of pseudoexfoliative material on the capsular surface. This study looked at the presence of pseudoexfoliation by examining iris transillumination defects, and this can be one way of picking up pseudoexfoliation in those patients who might be pseudophakic, or in patients where it might be difficult to ascertain if they have pseudoexfoliation on the anterior lens capsule. So looking for these specific peripapillary iris defects. In terms of genetics, genetics is certainly not my strong point, but there has been a strong genetic association with lysyl oxidase-like gene 1. This is a gene that codes for an enzyme which leads to the formation of matrix proteins and elastin fibers within the eye, and it has a strong association with pseudoexfoliation. And interestingly, it has no association with primary open-angle glaucoma. So within the eye, lysyl oxidase-like 1 enhances the cross-linking of elastin polymer within the eye. So a deficiency in the gene that codes for this leads to degradation of metalloproteases and matrix. Interestingly, within Saudi Arabia, this work done by Khalid Abu Amero has also shown that the similar genetic defects or subtypes of these LOXL1 genes are found in the Saudi population as well. How does the condition present? Well, the various stages have been described, and this is a classic paper by Neumann. And he described these 4 characteristic stages of pseudoexfoliation clinically. In the preclinical stage A, there is no obvious pseudoexfoliation. Now, in these eyes, interestingly, some of these eyes, pseudoexfoliative material can be found on conjunctival biopsy or examining the eye with an electron microscope. In the suspected pseudoexfoliative condition, there's an early precapsular layer on the lens surface or the iris, which can be easily missed. In the 3rd stage, which is called the mini pseudoexfoliative stage, a focal defect of white material is found on the superior nasal part of the lens. And in the last stage, the classic pseudoexfoliation, we see the characteristic bullseye or target lesion that's easy to spot in our patients. And this is a very interesting paper if anyone fancies reading it, and a very nice review. So how does pseudoexfoliation present? Well, it can present in a number of ways. It can present either as an open angle glaucoma, it can present as a narrow angle or acute angle closure type glaucoma, or it can present with certain lens features. So in open angle glaucoma, most commonly presents as a primary open angle glaucoma or similar to that. It can also present as a pseudoexfoliative crisis with very high pressures of more than 50. It can present with angle closure, and it can present with lens features like cataract can be the initial feature why patients might seek medical help because of reduced visual acuity from cataract, and occasionally can present with lens subluxation. So presentation of the condition is usually unilateral, although studies that have been shown that you can actually detect exfoliative material in the fellow eye by conjunctival biopsy, and that makes sense, of course, because it is a systemic condition. The condition is characterized by poor dilatation of the pupil and pigmentation of the angle, and it's characteristic material throughout the anterior segment. So this is a typical patient. This is a patient with pseudoexfoliation, and we see an early kind of target lesion. The pupil's quite small, not dilating properly, and we see pseudoexfoliated material on the pupillary margin as well. Often we'll see a characteristic pseudoexfoliated material in the angle, pigment anterior to Schwalbe's line and a Sampolesi's line. And this can be an important sign in those patients who are pseudophakic already. Occasionally, you can get clumps of pseudoexfoliation on the corneal endothelium, and this is often missed because we don't really look for it. And we can, of course, see material on the ciliary processes, and this is usually apparent when we do ECP in these patients. So Sampolesi's line is characterized by this wavy hyperpigmented line anterior to Schwalbe's line, and can be an important sign of the disease. It's not pathognomonic of this condition. It can also occur in pigmentary glaucoma and other types of condition which liberate pigment from the eye, like uveitis, but it's most commonly seen in pseudoexfoliation. So what are the features associated with pseudoexfoliation? Well, this is a study done here in Saudi Arabia, and these are the most common features, clinical features seen in patients who have pseudoexfoliation. So firstly, flakes on the iris margin is the most common feature. And then flakes on the trabecular meshwork, and then high intraocular pressure. And lastly, occludable angles, which about 10% of the patients with pseudoexfoliation have occludable angles. Of course, here we see a lot more patients with occludable angles versus pseudoexfoliation, and that could be due to the biased population that we see here, because we only receive the patients with advanced glaucoma and high pressures. And maybe many of the patients that have lower pressures and open angles that don't actually end up getting referred here. So pseudoexfoliative crisis we talked about earlier, and this is an example, a patient I saw during my fellowship a few years ago, a 72-year-old lady who had an odd feeling in the right eye for a couple of months, good visual acuity and pressure of more than 50, and mild corneal edema, but with an open angle. So obviously if she had this similar presentation with a closed angle, you'd be thinking of acute angle closure, but she had an open angle, and the disc cupping had progressed in the last few months. And because there was no room in the OR the same day, we had to do a paracentesis to get her pressure down, and eventually she ended up having a phacotrabeculectomy. One unusual presentation that I saw in one or two patients was pseudoexfoliation and pigmentary glaucoma together. And this is highly unusual, but this patient that we also saw in Canada was a patient who had pseudoexfoliation and was a high myope, so also had pupil rubbing the anterior lens surface, creating liberation of pigment. So the patient actually had both pigmentary and pseudoexfoliated glaucoma. So this is highly unusual, never seen it here. So there are various ways in which you can develop angle closure from patients with pseudoexfoliation. Over here, I think a lot of people have predisposed narrow angle. They have small eyes anyway, and smaller axial lengths and shallower anterior chambers, and for that reason develop angle closure. However, you can also develop angle closure from lens, anterior subluxation of the lens, and also from reverse pupillary block, which is the unusual mechanism that I showed in the previous slide. This is a study done by Peter Wishart in the UK, and what he did was looked at 76 eyes with patients with exfoliation, looked at the angle status, and what he found was about 1/7 of the patients with exfoliation had angle closure. So although we think of pseudoexfoliation being associated with open angles, a significant proportion of these patients tend to have angle closure. And other studies have shown the same thing. So in the Chennai eye study, about 11% of the patients had narrow angles, angle closure, and in other studies, the figures are variable. In a study done by Salih Obadan, he found nearly 40% of patients had closed angles. And of course, that was done in the tertiary care eye center, which was a referral population that could explain the higher figure. Now, those patients who have narrow angles, how do they present? Well, this study done in 1964 by Lowe shows that they can present either with subacute episodes, acute angle closure, or acute on chronic closure, so a mixed mechanism time picture. But the interesting thing is 215 out of 250 patients, so 90% of the patients present with acute angle closure of those patients that have narrow angles. Now, one interesting thing is why do they develop angle closure? Well, if you look at these eyes, the AC depth in these eyes, and this is a study, anterior segment OCT study, that looked at pseudoexfoliative eyes and also normal eyes. And with pseudoexfoliation, they looked at patients with unilateral pseudoexfoliation. So they looked at the eye with pseudoexfoliation in the fellow eye and a control population as well. And what they found was the fellow eyes, the fellow normal eye of the patients with pseudoexfoliation had narrower anterior chambers and narrower angles than the normal control. So even the eyes that appear normal in patients who have pseudoexfoliation in the other eye have narrower angles than average. So that could be one reason why they're more susceptible to develop angle closure. So we talked about angle features. Patients, even pseudophakic patients, can develop problems. This is a patient with capsule phimosis, patient who had pseudoexfoliation, and this is one reason to make a big rhexis in these patients. Although this can be easier said than done, these patients usually have small pupils, so it's difficult to make a big rhexis. But these patients can later on get capsular phimosis, which interferes with their vision. This is another patient who developed a dislocation of the lens after cataract surgery, and this had to be fixated. I'm sure you've all seen fixation of intraocular lenses. So this is one patient who developed dislocated IOL during my fellowship, and we fixated the lens on one side. And you can see here we made a scleral flap 1.5 millimeter behind the limbus, and we're docking the needle using a 25 gauge needle using a 9.0 proline and passing on either side of the haptic to fixate this haptic. Now, the treatment of pseudoexfoliation is very similar to primary open-angle glaucoma. It doesn't really vary much. Myotics can be effective, because they might reduce the rubbing of the iris on the lens surface and reduce the liberation of pseudoexfoliated material. But there is problems with using myotics in these patients, posterior synechiae, which makes cataract surgery more difficult, and patients often complain of reduced visual acuity. And there's some suggestion that prostaglandin analogs might be better than beta blockers, but I've not come across any definite evidence for this. But of course, prostaglandins do tend to reduce intraocular pressure more than beta blockers anyway, and so it's sensible to use these as first line. SLT is an effective treatment for pseudoexfoliation, and this Cochrane review a few years ago now concluded that it should be further investigation into the effectiveness of SLT, particularly in diagnostic groups such as pseudoexfoliation. So we're lacking some evidence, but the few studies that have been shown that SLT can be effective in these patients. And this study by Shazli showed that pre-SLT, the IOP was around 25.5. At about 1 year, it had fallen by about 5 millimeters of mercury. And by about 3 years, it had fallen to 18 millimeters of mercury. So pseudoexfoliation responds quite well to SLT. Does it respond better to SLT than primary open-angle glaucoma? That's a question that's not really been answered in the clinical trial. The LIGHT study, which was a study done to look at the effectiveness of SLT in patients with primary open-angle glaucoma and other types of open-angle glaucoma, had very few patients with pseudoexfoliation, so it does not provide us any conclusive evidence for the use of SLT in pseudoexfoliation. But the other studies that have been done show that it's likely to be effective. One thing to remember is that cataract surgery can itself be a very effective way of reducing intraocular pressure in patients with pseudoexfoliation. And this was the tip of the month of the European Glaucoma Society a few years ago, that pseudoexfoliation can respond very well to phacoemulsification. And probably dual mechanisms for the effectiveness of this. First of all, just irrigating the eye can wash out some of the pseudoexfoliated material, but secondly, removing the lens obviously opens up the angle in some of these patients. So probably acts by a number of mechanisms. And this is a study done by Karim Damji in Canada, and what he did was to look at patients with pseudoexfoliation who had cataract surgery, and look at a control group with glaucoma and a control group with just cataract. And what he found was that these patients with pseudoexfoliation, they had a much greater reduction in intraocular pressure. So the pressure went down by about 4 millimeters of mercury at 2 years, compared to 0.5 millimeter of mercury for the control. So always think about whether cataract surgery alone, especially in those patients with mild early glaucoma, might be an effective method to control their glaucoma, particularly if they have symptomatic cataract as well. Now, the problem with cataract surgery in these patients is that it's associated with a higher complication rate. And this is a systematic review, which means it's a study which pulled all the previous studies together to look at how risky cataract surgery is in patients with pseudoexfoliation. And what you can see is that the overall risk ratio is 2.13, which means cataract surgery is associated with twofold risk, at least a twofold risk higher of complications, posterior capsular rupture, compared to patients without pseudoexfoliation. And some of the studies have shown, in fact, that there's a 34-fold risk of doing cataract surgery in patients with pseudoexfoliation. So it is associated with a high risk of complications compared to patients without pseudoexfoliation. So that's something that patients should be told about. And the problems of cataract surgery arise from various issues: poor dilatation, weak zonules. The cataracts tend to be more dense sometimes. The anterior chamber can be more shallow, particularly with the eyes we see here. And there's some reports that the cortex can be more difficult to remove. So often these patients will require hooks, and in this particular patient, the hooks are being used not only to hook the pupil, but also to hook the capsule because of phacokinesis. And this can be a useful maneuver to help carry out the procedure safely and remove the lens. And then you can use the hooks again to hook the pupil, and you can insert a CTR again later on if needed. And Ultimed has devised these hooks, which are more safe to hook the capsule. The normal hooks can tear the capsules. You have to be a little bit careful, particularly the slightly cheaper ones, which tend to be a bit more thick and a bit sharp on the edges. So you have to be a bit careful when you're hooking the capsule with those. What about ECP? Is it effective? Well, ECP is probably less effective in pseudoexfoliation compared to primary open angle glaucoma and primary angle closure. And this is a study done here by Jose Morales and Deepak Edward. And I think a couple of consultants here were also on it, Sami Shawan. And this is in 2015, where they looked at success of ECP and cataract surgery in different types of glaucoma. And what they found was the success rate in pseudoexfoliation was about 30% at 12 months, whereas the success in primary open angle glaucoma is around 70%. So it probably is less effective and probably has lower intraocular pressure reduction compared to primary open angle and primary angle closure. And often you find that the ciliary processes in these patients with pseudoexfoliation have atrophied and don't take up the laser energy very readily. So what about trabeculectomy? Well, trabeculectomy is still the drainage procedure of choice in patients with pseudoexfoliation and works, my experience is it works very well. Although the literature is a bit conflicting, but this study done by John Landers from Cambridge showed that pseudoexfoliation carries a very good success rate in patients with pseudoexfoliation. And the success rate was about 50% at 20 years, and at 10 years, about 70%. So this is a qualified success, so that's with or without drops. Patients with pseudoexfoliation had success of up to 90% at 20 years. Other studies, though, have reported opposite results. This is another study, but this is retrospective data and shows that qualified success in patients with pseudoexfoliation is below 80%, and patients with primary open angle glaucoma have a success of more than 90%. Deep sclerectomy can also be effective, and this study showed that deep sclerectomy can be effective in patients with pseudoexfoliative glaucoma, and certainly that's our experience here as well, that patients who have open angles tend to do very well with deep sclerectomy. This study looked at patients with pseudoexfoliation and without pseudoexfoliation and compared them to having deep sclerectomy and deep sclerectomy with cataract surgery. And what they found was that the deep sclerectomy was effective at reducing intraocular pressure. In patients with pseudoexfoliation, the pressure was reduced by about 5 millimeters of mercury, and those patients with pseudoexfoliation and cataract surgery had pressure reduced by about 6 millimeters of mercury. The role of MIGS in pseudoexfoliation is still to be evaluated on a wide-scale prospective basis, but certainly anything which seems to target the trabecular outflow seems to be fairly effective in pseudoexfoliative glaucoma. This is a study looking at the eye stent, and what they looked at was the reduction in intraocular pressure and the number of medications at 12 months and 24 months in patients with pseudoexfoliative glaucoma. And what they found was at 12 months, the pressure was reduced by about 5 millimeters of mercury. And this is a prospective study. And they found that the number of medication could be reduced from 1.5 to under 1. So it seems to be an effective procedure in patients with pseudoexfoliation. So in primary angle glaucoma, they found at 12 months, the IOP reduced by 33%, and in pseudoexfoliative eyes, the mean IOP decreased by 32%, so fairly similar. And the medication burden also decreased. And this was a prospective, non-randomized 3-year study. So what about systemic associations? Well, let's not forget that pseudoexfoliation is a systemic condition, and deposition of pseudoexfoliated material has been demonstrated in other bodily tissues, including the cardiovascular system, central nervous system, the kidneys, and there has been reports of increased mortality in patients with pseudoexfoliation. So this is a summary of different studies that have been done to look at the location of pseudoexfoliated material and their effects throughout the body. One study looked at whether pseudoexfoliation would lead to an increase in cardiovascular and cerebrovascular disease. And what they found is in patients with pseudoexfoliation, the prevalence of cardiovascular disease was 9%, which was 3 times higher than controls. And patients with pseudoexfoliation had a 20% risk of cerebral vascular accidents or stroke, compared to 6% in a control population, so also 3 times higher. So this was a meta-analysis, which is a pooled analysis of a lot of studies, and it did seem to indicate that patients with pseudoexfoliation have a higher risk of cardiovascular and cerebrovascular disease. And overall, the odds ratio was 1.5, meaning that patients with pseudoexfoliation have a 1.5 times the risk of cardiovascular disease compared to patients without pseudoexfoliation. So in summary, pseudoexfoliation has a high prevalence in some parts of the world, including here in Saudi Arabia. It carries a significant visual comorbidity, mainly from glaucoma, but also from cataract. And of course, cataract surgery is not straightforward in these eyes and can be associated with significant complications. And it's a challenging condition to treat, and an intriguing condition regarding the pathogenesis and genetics of disease. Okay, thank you very much.
Thank you, Malik, for such a wonderful lecture. Any questions from the audience? If not, there is Dr. Asa Maktabi is asking to share some histopathological images. I said that I guess you don't have an inconvenience, right, Malik?
Some histological sections.
Yeah, she has some pictures of histopathology that she wants to share.
Okay.
I guess that it could be possible now to share the screen, right? Don't regulate that, isn't it?
Yes, if she wants to share, more than welcome. Yes.
Okay. So go ahead with the sharing of the imagine Asa Maktabi, please.
Thank you very much, Dr. Malik, for this very informative and nice lecture. I would like to share just some histopathological photos that I own from Dr. Ralph Eagle, who is a well-known ocular pathologist. So, sorry. So here in the top left quadrants, we can see the grossing of the back of the eye, where you can see the ciliary process, and you can see beautifully the pseudoexfoliative material precipitate on the zonules, and this is the border of the lens. And the histopathological characteristic is the sawtoothing of the pigmented iris at the back. And here beautifully we can see this iron filling pseudoexfoliative material at the anterior to the lens capsule. And here we can see it as well at the ciliary processes. And I think all you know that the material is glycoprotein. So I'm sorry not sharing this with you earlier, Dr. Malik, and thank you for giving me this chance.
Oh, beautiful images. Thank you very much.
Okay.
Thank you for sharing. Great images. So any questions from the audience to Dr. Malik?
So Conrad, I have a question for you, just from our observations here. You know, most people talk about narrow angles with patients with pseudoexfoliation because of lens subluxation, right? But in my experience, when you do cataract surgery in these patients here, the lens doesn't appear that unstable in most patients. And at home, when we do this surgery, we usually have to put CTR in or hook the capsule when we're doing phacoemulsification. And they tend to have stronger zonules. So that makes me think that the narrow chamber is not due to lens subluxation, but just due to anatomical predisposition of the smaller eyes that we have here. Do you have any thoughts regarding that?
Well, I'm agree with you because not always in this narrow angle, as you well said, there is a displacement of the lens. But another thing is that sometimes you have the idea that it might be certain degree of elasticity from the sonula. That doesn't mean that it's a disinsertion, but there is the capabilities of moving a little bit forward. Anyways, I believe that narrow angle in these cases are more due to an anatomical predisposition, as you said. But I think that all the cases that we had, and we're going to go for a cataract surgery, we should be prepared, thinking that it might be related to an anatomical condition, but also it could be related to a subluxation in order to be prepared for it, right? That is my thought. And one question for you, Malik, because in Europe, we don't see this thing. Have you noticed the same issue in England? At least in Spain, it's very rare to have narrow angle with pseudoexfoliation. What about in England?
No, it's very rare indeed. The only people you see it in is the migrant populations, right? So sometimes we have a few Ethiopians and Somalis and things like that. And in those people, you might see a narrow angles associated with pseudoexfoliation. And I think it's a shame, really, because this is a really gold mine for a good epidemiological study characterizing this type of glaucoma with pseudoexfoliation and narrow angles. I think would be a very nice thing to do here.
Yep, absolutely agree. And another thing, what about, other systemic issues? Have you noticed in your patients here related with pseudoexfoliation patients related with, for example, deafness or heart problems or any other conditions that you can say, okay, yeah, it's related to what we have written in the studies?
Yeah, it's a difficult question to answer here because I find here patients generally have a lot of comorbidity anyway, right? And we tend to see ischemic heart disease at a younger age. We tend to see type 2 diabetes at a younger age. And I think most of our patients, if you ask them, will have some form of comorbidity. So it's difficult to know whether, and most of them have pseudoexfoliation as well, right? More than half probably have pseudoexfoliation if you carefully look for it. So I think it's difficult to know whether there's an association or not in our tertiary population, but that's again something that will be very nice to look at in a screening population.
Absolutely. I think we are going to wait when you return after your experience in the colder weather, and you need to come for the warmer one.
Inshallah.
So, any other comments? Well, mainly, as you can check in the chat, there is a lot of good wishes to you. And I'm totally agree with all of them. I think this is one of the most memorable lectures that I have here in the recent years. Thank you, Malik, for sharing this knowledge, these thoughts, this wisdom with us. I don't know if I will suggest to everyone that is in the audience that we should take the advantage of asking Dr. Malik anything. He's willing to answer all of our queries.
How cold will it be in Canada?
Well, I think we need to change your background to snow, and then we might have some idea.
Hi, Dr. Malik.
Hi, Saad.
Salam. Thank you for this nice lecture. Just I have a question about if you have the choice and you have a patient who's having cataract and he's not controlled on medication, and you are going to do a combined procedure. So what is your preference, either to go for a trap or for tube surgery? Because, you know, some people that they mention the tube surgery and pseudoexfoliation combined with cataract is the success rate is more than the trap. So what is your preference?
Yeah, so I mean, generally, I tend not to do phaco traps in our population very much. And the reason is even traps are hard work. So basically, you know, if patients don't use the steroids, if they don't attend weekly for the first few weeks, then traps are likely to fail. And some studies have shown that phaco traps carry a higher failure rate than just trabeculectomy. So for that reason, I don't favor, and I don't do many phaco traps. And if I have to do combined procedure, then I usually go for a phaco tube.
Okay, what about deep sclerectomy?
Yeah, I think deep sclerectomy is a good idea. If they have an open angle, then I think phaco DS is a good idea. And Dr. Conrad can probably give us more information on that because he does quite a few phaco DSs in these patients.
Yeah, I'm agree with you. If I have the option, and I will prefer to go for a DS before a trap. I think that also the only inconvenience that you can find in a DS in pseudoexfoliation is that with time, this pseudoexfoliative material will block the trabecular measure window, even if the surgery was working good. The good point is that we have to be careful and detect it right on time. So if the goniopuncture is done earlier in this kind of patients, usually you can make the DS working, keep working, you know, but that's the difference between primary open-angle glaucoma and pseudoexfoliation regarding the DS, that the pseudoexfoliative material can block the window.
Mm-hmm.
But I think it's safer anyways, and as we always said, it can give an option for a second surgery later on.
Yeah, that's a good point.
I'm seeing that Badria, someone has the hands rise. I cannot completely read the last name, but go ahead, you can ask. Badria? Or probably it was the finger up in a state of being the rising the hand. Yeah. And Malik, another point regarding the cataract surgery, in your opinion, should it be done earlier? Should you wait? What is your advice regarding the right timing for the cataract surgery in pseudoexfoliative cases?
I think the earlier you do it, the better in these patients, and also in the patients with angle closure. And of course, we have a lot of patients with both. And if you open up their angle earlier on and you get rid of the pseudo exfoliated material, you might save them from a trabeculectomy or tube later on. The only issue is removing, a virtually clear lens and pseudo exfoliation. There's not much evidence for at the moment, but certainly I think it can save them a lot of visual comorbidity in the long run.
Good, I agree. Mm-hmm. Any cautious that you will recommend to the residents and young fellows that we have regarding the surgeries in this kind of cases, both of them, glaucoma surgeries and cataract surgeries?
Yeah, so with cataract surgery, I would, often these patients have very high pressures, so consider giving them Diamox beforehand, giving them intraoperative mannitol. Consider making a paracentesis, allowing the eye to decompress first of all. They often have small pupils, so put in hooks if you need to. And Brian Little always used to say, if you think about hooks, use hooks, right? If they cross your mind even, just put them in, and it will save you a lot of hassle. And of course, they can get iris prolapse and stuff then because you've got small pupils. So make a longer corneal tunnel. Dilate the pupil as much as you can. Make a big capsulorhexis because they can get capsular phimosis later on. I always assume that they might have a degree of lens instability even if you don't see it. So do a gentle hydrodissection, do a few waves in different places rather than trying to move the lens around too much. And then chop techniques are always a bit better. And sometimes if the anterior chamber is not too shallow, even prolapse part of the pole up into the anterior chamber so that you're kind of not phacoing within the bag just in case the bag is a bit unstable. And then leave a good capsulorhexis. So in case things don't go too right, then you can actually at least put a 3-piece lens in the sulcus rather than rely on the bag if it becomes unstable.
Excellent. I hope everyone has write it down, those excellent tips, Malik. And regarding the pre-op of the patients, any additional test that you will require for this kind of patients, or you consider that could be useful in this kind of patients?
Yeah, so I think a significant risk in our patients with these narrow angles and pseudoexfoliation and very high pressures is corneal compensation, right? And we have to remember that their cornea can decompensate. And I've had a couple of patients whose vision went down and their cornea decompensated. And even with their PKP, they never got the same vision back again. So I think doing corneal endothelial cell count, which we often forget, is a very useful thing to do to counsel the patient, particularly if there's their only eye. Of course, these patients, the cataract surgery is not straightforward anyway, and then at least they have a choice then whether to go ahead with the surgery or not.
Great. You consider any anterior segment imaging that it could be helpful in these cases, or you think that is not as a standard?
I don't do any anterior segment imaging as standard. But I guess it's not a bad idea to have an anterior segment OCT and have a formal anterior chamber depth measurement and angle opening distance measurement as well. But I don't do any routine anterior segment imaging. Do you do anything?
No, I don't do as a standard, but in those cases that you might think that the lens could be involved in the narrow angle, probably could be especially with the new technology of anterior segment OCT. I think that it can be useful in some of these cases,
Yes, agree.
It's the same thing with the previous evaluation, even in open angle glaucoma, when you do the gonioscopy and you have an idea on the high degree of pigmentation, usually tells you how bad that dispersion could be and probably how well these patients are going to respond to certain type of surgery.
And what's your experience with eye stent in pseudoexfoliation? Have you found it to be quite effective?
I think that the eye stents will work depending on the right choice of patients, but among them, open-angle glaucoma, pseudoexfoliative glaucoma, early stages will work. As most of the surgeries in pseudoexfoliative cases, later on, it might stop working because of the blockage of the trabecular meshwork. The same thing with the Cahook, at least at the experience. It seems that the Cahook works very good in these kind of cases, maybe because it's the 120 degrees removal of the trabecular meshwork. What about in your experience with the ABIC or the GAP? Do you think that it has a place for it?
Yeah, I think any of those procedures, you know, which remove the trabecular meshwork and get rid of that pseudoexfoliation material, at least in the mild cases, can work pretty well. And the trabectome, you know, were reported to have good success in these eyes.
Yeah, yeah. I think that at the end, you know, angular surgeries in pseudoexfoliation seems to be working good, especially if it's in an early stage. Of course, in an advanced damage, if we know that we need to reduce the pressure more than 30%, these angular surgeries are not going to reach that level. Agree?
Yes, agree.
And what about the Shen? Now that we had it.
Yeah, I mean, I don't have any experience with the Zen, so you're probably in a better place to tell us about that. But, you know, with the Zen, my feeling is that, you know, with the patient population we have with the unhealthy conjunctiva and the rates of scarring, I think the rates of needling are going to be very, very high, and the failure rates are going to be high, because in the Caucasian populations, you know, it's been reported as 40% needling rates. So I'm not too optimistic in our eyes, but I think in those patients who have thin conjunctiva and who have very little choice as to what else can be done in elderly patients, I think it might be a good choice.
Plus, you know, to add to this observation, the important thing with the Shen is also being able to detect when stop working and do the needling in that moment. And, you know, my experience here is that sometimes when you want to give the appointment to the patient and say, well, come and see me in 3 weeks because it's the precise time that I need to control that surgery, you receive answers like, oh no, doctor, I cannot come in 3 weeks because it's not good for me, you know. So I think that the care of the glaucoma surgeries depends a lot on following the patients in a close way, and sometimes that is an issue. Absolutely.
Yes.
Well, great, Malik. I can't thank you enough. You know, we're gonna miss these lectures that you give us and all the tips. Maybe we're gonna reach you there in the underground and with the cruel winter that you are starting to face. Anyways, I can thank enough Dr. Malik for this beautiful lecture. We are 3 minutes before the time. I don't see any other question or any other comment. If you want to say one last thing, other way we can end the session.
No, thank you very much. Thank you for moderating, and thank you. It's really been a pleasure. The teaching activities here have been highly stimulating, and it's been a pleasure to train the residents and the fellows and interact with the faculty.
Thank you, Riz. We're going to miss you. All the best.
Thank you.
Okay, thank you then, and we close the session. Thank you.